This is another interesting case that Antonina Kalmykova shared with me. As usual, I don't have any clinical history, but I do believe this biopsy specimen came from the lower leg. Now, I'm just going to close this window and reopen it to enable me to show you the two pieces of tissue. And you can see at first glance that there are notations. In fact, this entire specimen, there are 37 annotations in two different slides, and the annotations conform to the presence of mitotic figures. So before we start looking at this tumor, we know it's mitotically very active. And I'll just straighten this slightly, and we can see that there's a tumor which is very close to the epidermis. I don't know whether it's arising there yet or not, and it is extending deeply into the dermis, almost to the level of subcutaneous fat. So one is, if we combine that low power view and Antonina's annotations, I think we can have a pretty good idea that this is not going to be a good news tumor. So let's have a look at this at higher power now. And I just want, yes, this is the bit that I want to get to first because it's really very interesting. So we're right out at the edge of the tumor, and we can see there's something happening in the epidermis, and we'll look at that at a slightly higher power just to get an idea of what's going on. And what we can see is there's an intraepidermal component, at least I think it's intraepidermal. You might argue it's occupying a whole dermal papilla, and these are stretch Rete ridges. There I think it's maybe slightly more convincing that it's arising from the epidermis. We'll have a look at that at higher power. What one can see here is a very circumscribed and rather uniform population of cells, which at high power, well, I suppose one's instant impression is they have a poroid appearance. Let's look along at the other bit. And there's Antonina's really worked hard at this. There are, gosh, 1, 2, 3, 4, 5, 6 mitoses she's managed to pick up. And the other thing that we can see very nicely in this field is there's a lumen, and if you look at the edge, there's an eosinophilic cuticle. So that's ductal differentiation. So we've got a tumor which looks poromatous, it's very mitotically active, and it certainly does show ductal differentiation. There's not a lot of nuclear pleomorphism, really. It's not a desperately pleomorphic tumor. I suppose there is some variation in nuclear size, and in some cells nucleoli are a bit prominent, but I wouldn't get too excited about it. So let's go back to a low power. So that was the edge, and then we can see lots of tumor in the dermis. I just want to, maybe I'll go back to ×2. I just want to get us to the main bulk of the tumor, which is here. So unfortunately, there's a tear in the specimen, but we'll just have to live with that. And there you can see all these other notations, each of these representing a mitosis. So the one thing we don't have to do in this case, which is an absolute blessing, is we don't have to start gazing to find mitotic figures. Now, what we're seeing are large, I suppose you'd call them lobules of tumor. Some of them are elongated, and they just keep on and on and on. There's a bit of a lymphocytic infiltrate in places, and it doesn't really look as if it's showing much variation from top to bottom. So let's have a look at the top of the lesion and see what we can find. Now, well, it remains poroid. There's another mitosis, just for good measure. I just really want to see how much ductal differentiation we can pick up. Maybe if we go to a ×20, it'll be a bit easier, because I mean, I don't think there's any doubt in my mind that this is a porocarcinoma or a malignant eccrine poroma. A, because of the growth pattern, and B, because of the mitoses. I suppose we'd have to call this well-differentiated porocarcinoma, although I don't think that there's any, at least as far as I'm aware, that I don't think there's any particular significance in talking or in thinking in terms of well, moderate, or poorly differentiated. Now here we are. You see, if you keep looking, you always find what you're looking for. It's just one has to be very patient. There are another two intracytoplasmic lumina or ducts. Again, you can see this eosinophilic hyaline cuticle around with the nucleus shoved to the side. There's another one there. So we're getting a reasonable number of ducts. Now, the other thing you have to look for in a porocarcinoma, because I think it does have prognostic significance, is to see whether you can find any perineural infiltration, and more importantly, lymphovascular invasion. Porocarcinoma is high-grade tumor. It has a recurrence rate, I'm going to estimate it around about 20%, and it probably affects lymph nodes in maybe 15% of cases. And I think disseminated systemic disease occurs in maybe 10 or 12% of cases, so it can kill you. And so this is, although sometimes you may confuse this with, say, a sort of a well-differentiated non-keratinizing squame, the important thing to remember is porocarcinoma has a metastasis rate that can kill you. Squamous carcinoma of the skin metastasizes in only a very small percent of cases, unless there are certain circumstances. For example, squamous carcinoma arising in scar tissue is a high-grade tumor. One of the things I learned in my time working with epidermolysis bullosa patients was that well-differentiated squame in that situation was often the end of the story for the patient. There's a very high risk of metastatic disease. Now, I think we've got some immunohistochemistry, which I don't think we need, to be honest with you. I don't think you get anything out of it in this tumor. But we'll look at EMA and CEA. I don't know what else Antonina did. She probably did all sorts of things, but one of the things I've learned, and I'm pretty consistent about, is this: if you look at an appendage tumor and you don't know what it is on the H&E, then I have little faith that I'm going to advance myself too much with immunohistochemistry. It's useful sometimes to use the immunohistochemistry just to confirm your diagnosis. And if I'm not being too cynical, it's quite nice if you're going to present a case at a meeting, because the audience are always going to love some pretty immunohistochemistry. But anyway, this is EMA, and the whole thing's EMA positive, which doesn't tell us anything really. Squamous carcinoma can be EMA positive, so that doesn't really help us. Now, if we're lucky, these ducts, oh, there you are. Now that's quite nice, because you've got a sort of an accentuation of that duct there, and there's another one there. It's just the EMA is so positive, it's hard to pick it out. But if you wanted EMA to confirm ductal differentiation, then that can be useful. I'm going to look at CEA in a minute or two. I just thought we'd wander around this a little bit longer. We'll go to the lower part, because we've got a couple of bits of tissue here. There's another bit there. It's just the edge of the tumor. Okay, well, I don't think I'm going to waste time on looking at EMA anymore. Now I've just got to find CEA. You can see, if you look at the top here, there's an endless numbers of immunohistochemistry. Antonina is obviously a great immunohistochemistry fan, as most of you are. It's something I've noticed when I look at your cases on McKee derm. I end up totally bewildered at all of the immuno you order, none of which I've ever heard of. So it's a sort of I find myself at a great disadvantage. Well, it looks as if CEA is negative, so I'm not going to worry about that too much. So just to summarize, we've got a lesion, I think, on the leg. It's porocarcinoma by virtue of its mitotic activity and its deep growth pattern. It's not a pleomorphic example. Porocarcinoma, to my mind, is one of the more common high-grade sweat gland carcinomas. I think in my days I've seen more porocarcinomas than anything else in that category. They mostly occur on the legs. You can certainly see them on the soles of the foot. And in about 10% of cases, they may arise in a pre-existent poroma. And that sometimes you see that histologically, but it's really quite uncommon to actually see a transition between one component and the other. Sometimes porocarcinoma can look very bonoid. It can keratinize, and you have to look in the deep aspects to get more obvious poromatous tissue. So that's a catch, particularly if you get a shave biopsy, which sometimes the dermatologist will send you. It's one of the great mysteries to me, is a patient presents with a 5 centimeter diameter tumor on the foot, and somebody sends you a shave biopsy. I mean, it's just mind-blowingly ridiculous, but it does happen. And there are other interesting variants. You can get a pigmented porocarcinoma. It can be stuffed full of melanin. You may get a clear cell porocarcinoma due to glycogen. And very exceptionally, you may see a sarcomatoid porocarcinoma, if you like, a metaplastic carcinoma or carcinosarcoma. And that's about all I can think of to tell you about porocarcinoma. So I hope you've enjoyed this video, and I've enjoyed looking at it, and thanks again to Antonina for sharing it. So thank you very much.